Hello friends, today we'll be discussing the topic of bariatric and metabolic surgery. So these are useful for reducing obesity. Before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. And the link for the notes is given in the description. You can download it from there or from my Telegram channel. So let's get started. What are these indications? What are the indications for these bariatric surgery? So if the BMI is more than 40 kg per meter square or it is more than 35 kg per meter square with medical comorbidity which has been worsened by obesity. This is for the international guideline. In case of Asian population, we reduce 2.5 kg per meter square from these guidelines. Like normally it will be if the BMI is more than 37.5 and with comorbidity it is 32.5. Also, there will be failed dietary therapy, psychiatrically stable patient without any alcohol or drug use, motivated and knowledgeable. Now, what is the criteria for metabolic syndrome? So, abdominal obesity, waist circumference in male more than 40 inch, in female more than 35 inch, hypertriglyceridemia more than 150 mg per dl, low HDL, less than 14 male, less than 15 female, high blood pressure, more than 130 by 85 mm of Hg, high fasting glucose, more than 110. So if more than equal to 3 criteria, then it is a metabolic syndrome. Then coming to BMI classification. So in international, normal is 18.5 to 25. And more than 25 is overweight, 25 to 30 is pre-obese, more than 30 is 30 to 35 is class 1 obese, 35 to 40 class 2 obese, and more than 40 is class 3 obese. In Asian population, 18.5 to 23 is normal, more than 23 is overweight, 23 to 27.5 is pre-obese, 27.5 to 32.5 is class 1 obese, 32.5 to 37.5 is class 2 obese, and more than 37.5 is class 3 obese. Then what is the mechanism for these effects in bariatric surgery? So weight loss dependent, that is caloric restriction causing long-term sustained weight loss, improvement in the glucose metabolism and lipid metabolism. Then weight loss independent, so bypass of duodenum, so there will be increase in exposure of nutrients to incretin secreting cells in small and large intestine, increase in GLP-1 secretion, improved glucose metabolism, alteration in gut microbiome. So these are weight loss independent. Apart from that, there will be neurogenic and hormonal changes which will be affecting the satiety and causing weight loss. Hormones involved will be ghrelin and neuropeptide Y. Now coming to types of bariatric procedure based on mechanism of action. So restrictive. In restrictive we have laparoscopic adjustable gastric banding, LAGB. So here we will apply a band in the stomach which will be controlled from the reservoir port. So here there is a placement of an inflatable silicone ring along the proximal stomach, and the band is placed through the window in the pars flaccida of the gastrohepatic ligament. Stomach is imbricated over the band and the band is attached to a reservoir system that allows adjustment of the band tightness, and this has access through the subcutaneous port. So in this manner we can control the tightness of the band through the reservoir port and adjust the size of the stomach. Then we have sleeve gastrectomy. Here the greater curvature is devascularized and a sleeve section is resected. It is contraindicated in GERD and Barrett's. Vertical banded gastroplasty, which was earlier done, is not done nowadays. Then coming to largely restrictive and moderately malabsorptive procedure. So these are Roux-en-Y gastric bypass. So the proximal stomach is connected to the Y limb, and separately a Roux limb is made which is connected to the ileum. So it has the Roux limb has the distal residual stomach and duodenum and jejunum. And the Roux limb, which is the distal part, that will have the distal jejunum and ileum, and the Y limb will have stomach, duodenum and the proximal jejunum. So minimum Roux limb length should be 75 to 150 centimeter, and more is the BMI, more Roux limb length will be required, and the Y limb will be around 25 to 50 centimeter. That is also known as the biliopancreatic limb. Then we have mini gastric bypass, where the 200 centimeter from DJ flexure, ileum is connected to the small intestine, ileum is connected to the gastric remnant. So small gastric pouch is created, which causes early satiety and caloric restriction, bypass of the duodenum. So there will be incretin stimulation, GLP-1 secretion, improved glucose metabolism. Along with that, there will be alteration in the bile acid levels, and which will cause improvement in the cholesterol metabolism. Then largely malabsorptive and mildly restrictive. These are the biliopancreatic diversion. These are rarely done nowadays due to technical difficulty and nutritional and metabolic complications. Then we have duodenal switch. Again, it is rarely done nowadays. Then single anastomosis duodenal ileal bypass with sleeve or loop duodenal switch, also known as SADIS, is rarely done nowadays. Then seeing some older procedure. So vertical banded gastroplasty, which was purely restrictive, and jejunal bypass, which was purely malabsorptive. Some of the recent advances. So we have endoscopic intervention. These are endoluminal restrictive procedure. For that we have endokinch, that is endoscopic plication of gastric wall to reduce the gastric lumen. Then we have TOGA, that is transoral gastroplasty, where we use an endoscopic device to suction the gastric mucosa to form a restrictive pouch. Then POSE, that is primary obesity surgery endoluminal. Here full thickness of gastric wall is plicated. Then space occupying devices. These are the intragastric balloon, which are radio opaque and reduce the gastric space and can be varied in size by filling of the saline in these balloons. Then some malabsorptive procedure. There's an endo barrier which is useful for duodenojejunal bypass. So it's an impermeable sleeve placed just beyond the hepatopancreatic duct, extending from the proximal jejunum, uh, extending from the duodenum to the proximal jejunum. So it is a barrier to mucosal absorption of nutrient, delays mixing of food with the secretions. So faster food is transmitted to jejunum and it can be removed endoscopically. It is placed and removed endoscopically. So this was all about bariatric procedures, and most commonly is the sleeve gastrectomy which is done nowadays. Complication of these is leakage from the resected part or the anastomotic part, hemorrhage from these part, nutritional deficiency causing iron deficiency or severe weight loss. Sometimes even there is recurrent weight gain, obesity again. So these are all the complications. So keep studying, keep growing, and never give up because great things take time. See you soon in next video. If you like the video, please like, share and subscribe. And thank you for watching. See you in the next video. Thank you.